Good afternoon, everyone. My name is Dr. Mandu Ekpenyong with Manchester Metropolitan University, presenting on factors influencing the utilization of maternal healthcare services in Nigeria. Maternal mortality trends in developing world have failed to reduce significantly, despite various policies and strategies, such as Safe Motherhood Initiative and many other initiatives to change the situation. In 2017, about 295,000 women died following pregnancy and childbirth. 94% of these deaths occurred in developing countries, and most could have been prevented with timely access to emergency obstetric care. Sub-Saharan Africa alone accounted for roughly 2/3 of maternal deaths, and Nigeria is among these countries. Maternal deaths are higher in some regions of the world where there is inequalities in access to quality health services, and this highlights the gap between the rich and the poor. Evidence has consistently shown that high maternal and perinatal mortality is associated with lack or inadequate skilled maternal health care services during pregnancy and childbirth, particularly in sub-Saharan Africa, where half of all maternal deaths occur. The development of poor health behaviors can have long negative effects on maternal health. Improving women's health during pregnancy and childbirth has continued to be a global priority. Maternal and child healthcare services are very important for the health outcomes of the mother and that of the baby, and in ensuring both maternal and child deaths are prevented. Maternal health care can be defined as the care given to a woman during pregnancy, childbirth, and postpartum periods to ensure good health outcomes for the woman and the baby. This comprises of antenatal care, labor and delivery care, and postpartum care. The international guidelines for utilization of maternal health care stipulates that utilization of antenatal care should be a minimum of 4 visits, and the first visit should be done during the first 3 months of pregnancy. Maternal care should be provided by a skilled birth attendant, and postnatal care should be done to both the woman and her baby immediately after delivery and within 2 weeks after birth and throughout 42 days after delivery. The main objectives of antenatal care are to deliver effective and appropriate screening, preventive and treatment intervention. Effective use of antenatal care contributes to better maternal outcomes and safer birth. Antenatal care also provide opportunity for assisting women to make birth and emergency preparedness plans. However, contribution of antenatal care to maternal mortality reduction has been challenged. High-risk screening during pregnancy, high-risk screening during antenatal care provide high-risk screening during antenatal care as a means of identifying women for facility-based delivery is not effective, since most of the antenatal care provided is of poor quality in many low-income countries. It is important to note that each pregnancy may end up with obstetric complications. There are many influences that impact on women's utilization of maternal health care services. Nevertheless, women's decision or women's choices in decision to seek care are constrained by numerous factors related to women experiences in reaching the health facility and at the facility. The provision of good and skilled care to women during pregnancy and childbirth is crucial, not only for saving the lives of the women, but also that of their child. In sub-Saharan Africa, particularly in Nigeria, significant change relating to health at the grassroots has failed. The use of top-down tactics in policy development and execution has failed to bring about the much-needed transformation. For this change to occur, real and active community involvement is crucial. Studying factors that influence the use of these services is necessary in developing countries where infrastructure is negligible. The aim of this study is to examine the factors that contribute to examine the factors that influence women utilization of maternal healthcare services in Nigeria. To investigate this issue, a mixed method using both quantitative and qualitative approaches was adopted. The population for the study were women aged 14 to 49 years who had experienced direct obstetric complications and were attending the healthcare facility at the time of this study. A total of 318 women completed the questionnaires, while in-depth interviews were conducted for 6 women who were conveniently selected from a large quantitative respondents. Both quantitative and qualitative, both questionnaire and semi-structured interviews were used in collecting data for this study. The study was carried out in one of the tertiary healthcare facility in Delta State, Nigeria. Data analysis, different methods were used in analyzing the data collected. For the quantitative study, statistical package for social science using both inferential and bivariate analysis was conducted. Logistic regression analysis was also used to test predictive power of the predictor variables. Chi-square test. Chi-square value was also calculated for significance at a significance level of 5%. Adjusted odds ratios, 95% confidence intervals were also calculated for each of the individual logistic regression models, and p-value were reported for bivariate analysis. For the qualitative data, content analysis was used in analyzing the data collected. Ethical approval was also obtained from the University of Wolverhampton School of Health and Wellbeing Ethics Committee, and also approval was obtained from the Ethical Committee of the Tertiary Health Facility where the study was conducted. From our findings, it was evident that the women who took part in this study were within the age range of 15 to 45 years, with a mean age as 26. Women's decision to utilize maternal healthcare services was based on the ability to recognize warning signs in pregnancy. The findings of the study revealed that majority of the respondents correctly recognized bleeding in pregnancy, convulsion during pregnancy, vaginal loss of fluid that is not urine before term, onset of preterm contractions, and persistent headaches were the warning signs that were correctly identified by the women who took part in this study. However, as high as 37% respondents mistook vulvar itching to be a warning signal in pregnancy. Again, women's decision to seek care was determined by computing a summary variable overall decision to seek care by aggregating 14 items on decisions and attitude of women. Options viewed to be more acceptable attitude of women towards seeking care was given a score of 1 point, while unacceptable attitude was given a score of 0. Total decision score was 14 points. Overall decision of women was characterized as poor if aggregated score was less than or equal to 4, fair if aggregated score was greater or equal to 5 and less than or equal to 9, and good if aggregated score was greater than 10 or equal to 10. Bivariate analysis of determinants of maternal healthcare utilization shows that marital status, monthly income, and place of residence, and distance to health facility all had significant association with maternal decision to seek care. The association was such that those with a slightly higher income above the minimum wage were more likely to make good decisions than those with income level below minimum wage at p-value equal to 0.01. Married respondents were also more likely to make good decisions to seek care than those who were single, separated, or widowed. Time taken to travel to the health facility was also significantly related to maternal decision to utilize maternal health care services. Those who traveled less than 30 minutes were more likely to report good maternal decision compared to those who traveled more than 30 minutes. Women who had no decision-making power were more likely to report poor maternal decision to utilize maternal health care services compared to women who had decision-making power. Women with formal education were more likely to make good decisions than those with no formal education. Cost of transportation was also associated with good decision-making to seek maternal health care services, with those who did not pay for transportation and those that paid little amount having more good decision to seek care than those with high cost of transportation. Both maternal income and cost of transportation to health facility remain predictive of maternal decision to seek for care in healthcare facility. Women with low income had lower odds of exhibiting good maternal decision compared with their counterparts who had higher income. When the cost of getting to a health facility was low, there was also a high likelihood of making good decision compared with an instance where cost of reaching a facility is high. This was statistically significant at p-value less than 0.05. Surprisingly, women who were unemployed were also more likely to make good decisions to seek maternal health care services in health facilities. Quality of care was also associated with a good maternal decision to make to utilize healthcare services in health facilities. Quality of care at the facility equally had impact on maternal service utilization as the likelihood of non-utilization was significantly lower when quality of care was reported to be optimal. This study has shown that mothers in this region where the study was conducted were not significantly utilizing health facility for skilled birth attendants during pregnancy and delivery care. The results also highlighted the need for improvements to promote present and future healthcare utilization. The findings based on the view of the study informant indicated many issues that should be improved upon for better utilization of healthcare services. This includes decision-making power, place of residence, distance, quality of care, travel distance or travel time, mode of transportation, cost of transportation to the health facility, all had a role to play in a woman's ability to utilize healthcare services in health facilities. The adverse effect of this on maternal health is that women will continue to be victims of pregnancy as lack of education and susceptibility to gender inequality, which gives them little control over their reproductive health, thereby putting them at risk of involuntary pregnancy and thus the risk of maternal mobility. Again, because of the complexity of maternal health, the solutions to maternal health issues need to be complex as well. Maternal health issues are not caused by one factor. So, effort to fight maternal mortality and mobility must also focus on different levels, such as the individual, environmental, and healthcare system level. A good knowledge and understanding of the influences of the various levels is very important to improving maternal health care or maternal health. Thank you very much.